fear, helplessness, dissociation, confusion, or other disruptive feelings intense enough to have a long-lasting negative effect on the person's attitudes, behaviours, and other aspects of functioning. Traumatic events include those caused by human behaviours, such as rape, war, industrial accidents, as well as nature, earthquakes, and often challenges an individual's view of the world as a just, safe, and predictable place. So you can see in that definition, there's lots of different variables. There's human behaviour, there's natural disasters, and they all revolve around how the person sees the world as being just, safe, and a predictable place. I suppose we all kind of hope that the world's going to be a predictable place, but whenever things happen, it can change our outlook. A helpful reference really for this is a DSM-5 diagnosis of PTSD. And if you look at that, it'll give you lots of different signs and symptoms of what the person will present with. And we'll be talking about some of these throughout the presentation. The ICD-11, which is due to be released in January of next year, has added in complex PTSD into its diagnosis, which is really good. I'm going to use a lot of pictures throughout this presentation, and I think pictures are really going to help us to understand and to really get into our heads what we're looking at. So there's a couple of different types of trauma. The first one that we're going to look at is single incident trauma. So what you can see here is just someone come down the road and a tree just blocking the way. So in single incident trauma, something stops you in your tracks. And our journey then is dealing with this incident. So you can see that road looks to be fairly good. And you can also see, if you look through the trees, you can see that there may be a chance of getting out of this. The road may be represented, if you want to look at it from a trauma point of view, the road may represent the family, maybe a solid family structure. Maybe it's a support. So nothing has happened, but this has happened, and now the person has to overcome this. But there still seems to be light at the end of the tunnel. That's single incident trauma. Happened once. The next one is potholes, okay? Multiple trauma, okay? This road looks a little bit less, a bit more scary, and you can see there's lots of different things have happened. So really, it's peppered with traumatic experiences. The road up to this could have been resilient, as in the person may have had a strong, stable base with family and friends. So there is areas of resilience there, but then you can also see lots of different traumatic experiences. So this is multiple trauma. So an example of this is a person may have had a car accident, but they also may have had a bad bullying incident. These two instances, in terms of the memory and how you see them, they may have both the same feelings of fear and threat. So what we're dealing with here is more than one trauma, so multiple trauma. In terms of a person getting well, single incident trauma is usually treated faster than multiple trauma, because there's a couple of other different traumatic experiences which the person may have to look at. And the third one is more of complex trauma, and you can see this looks quite slidey and quite slippery and quite scary. There doesn't seem to be a stable base there, and really it's someone who doesn't have a sense of themselves, poor attachment, and an unsafe environment. So in this circumstance, what they need to be in survival mode, and they may not have developed emotional capacity or a sense of self to be able to navigate themselves through the world. Okay, so complex trauma can be quite, I suppose, if you look from a trauma point of view, it's usually someone who's had quite a difficult childhood, maybe an abusive childhood, and also other things have led to that. So complex trauma will be the third slide. So there are different variations of trauma. So the reason why I put this slide up is whenever you're trying to understand the client's journey, the devil's in the detail, in that it's important to understand what kind of happened, okay? So we spoke about there's single trauma, single versus complex trauma. Single trauma is a once event, it's past, a car accident, a dog bite, okay? Complex trauma is ongoing, maybe ongoing sexual abuse. Maybe someone who has had quite a difficult childhood, and other events have often happened because of this. Okay, there's single versus multiple being a few things have happened. Okay, the age of occurrence, and this is quite an interesting one. The younger the person, the more profound the consequence. So an infant in their first year of life who's exposed to trauma will potentially develop regulatory difficulties and therefore also possibly attachment difficulties. So what I mean by that is, whenever we're listening to the client's story, it's important to understand what age was it whenever they had maybe a lot of their traumas. Again, what the research is showing us, and I'll be going through this later on, is that children and even younger than that, the people can be developed or can be traumatized at a very, 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 very young age. Okay, even before birth, that's what the research is saying. There's also pre-verbal trauma. So there's lots of little things that we need to bear in mind whenever we're trying to understand the client's story. So the age of the first, of whenever it first happened. What they're also saying in the research is that whenever the young children are more susceptible to developing trauma. Why? It's because they're more reliant on adults to be able to regulate them. They haven't got the necessary skills to be able to manage a lot of things. So if you have a child whose parents are also traumatized, that leaves the child in quite a difficult situation where they may be lacking these resources. Maybe, but maybe not. It's just something to be aware of whenever you're trying to gather the client's history. The third thing is the degree of interpersonal violence. Okay, so when a child is threatened, or when there is a threat of death, this traumatic experience is more difficult, and it can leave a really impact. It can really impact on the person. So whenever you add the violence into it, or the threat of violence, this is another thing to keep in mind whenever you're trying to help the person to understand their journey, and also to be able to help the person to become more well. The degree of dissociation during trauma, I'm going to speak about this later on, but just to briefly kind of bring it up. Dissociation is the brain's way, I suppose, of trying to escape whenever there's danger, whenever there's a trauma. So what the research is saying is that whenever someone dissociates during a trauma, it's more than likely that they're going to dissociate also during treatment. So dissociation is really where the person's brain, I suppose, goes off into an imaginary world, and it just doesn't want to be there. I'm going to go through it more, but again, just another thing to keep in mind whenever you're trying to gather data on the person's traumatic experience. The duration of the traumatic experience. Was the person involved in a bullying incident, or did the bullying incident last 2 years or 3 years? Again, this can all help us to predict the client's outcome, but also help us to understand what it was like for the client whenever they were in that journey. Okay, so the duration, was it once off, or was it several years? Was a perpetrator there? Again, just trying to understand the person's journey. Closest relationship to the perpetrator. Okay, so who was the perpetrator? What was the relationship? Was it a family member? Was it a friend? Again, it's all something to bear in mind whenever we're trying to understand what this person is dealing with and how some of their present symptoms may have resulted from their past events. I'm just going to stop there and ask, is there any questions on anything that I've said so far? Okay, I can't see any coming up at the moment. Infant memory development. Okay, over the last maybe 2 years, I've specialised and I spent a lot of time trying to understand the younger ages and psychological trauma. So infant memory development is something also to bear in mind. So Paris in 1990, what he's saying is a single experience in a psychological laboratory at the age of 6.5 months can still be remembered behaviorally and emotionally by children when they were 2.5 years old. Okay, so traumatized 6.5 months can still be remembered behaviorally and emotionally. So a book that was released there was that the body keeps score, and this is something that we should keep in mind, that the person mightn't actually remember in their mind what happened, but the body may remember what happened. Okay, and a lot of times whenever people are presenting with psychological trauma, what they find is they've talked about a lot of the events, but they still feel it in their bodies. Okay, that's because the body remembers. Infants aged 3 to 4 months who've been physically abused also manifest negative emotional expressions. Okay, so again, going back to that age, so we still need to keep in mind what age was the person. Okay, the facial displays of anger are thought to emerge between 7 to 9 months normally. The younger the child, the higher the risk of exposure to trauma than older children and adults. Why? It goes back to stability. It goes back to who's there to nurture the child, who is there to support the child after the event. So an interesting thing to look at is the child's reaction to traumatic event scale, the CRTES, which is aged between 6 to 18. Again, it's a more child-friendly version of the PCL5, which comes out of the DSM for PTSD. But again, it's nice to see that given the ICD-11 are looking at different, are taking into more account that younger children can be traumatized and what this looks like. Okay, the next thing I'm going to talk about and to help you to understand is in the EMDR perspective. So a lot of my talk has come from my EMDR training. So EMDR stands for Eye Movement Desensitization and Reprocessing Therapy. It's a psychotherapy. It's quite young. It was Francine Shapiro came out with it in, I think it was 1987. So in terms of other therapies, it's quite young. However, it is very well researched. It's endorsed by the WHO, National Institute Guidelines, and it's getting more and more recognition for what it's doing. So I'm going to give you a brief overview of what I'm talking about so that you can kind of see the lens of which I'm using. So EMDR therapy, it's an 8-phase psychotherapeutic approach that emphasizes the physiological information processing system in the origin and treatment of mental health issues. What we're saying here is that we believe that everybody has born with the ability to process a certain amount of distress and disturbance. What do? We talk to our parents about it, talk to our friends, we sleep on it, we argue. There's generally some sort of resolution to it. So we all have the ability to process it. However, whatever happens then whenever we're traumatized is things start to change a little bit. I'm going to go through this in a little bit more detail, but what we're saying is that the amygdala, which is normally there to understand what's happened, this becomes overwhelmed. It doesn't know what to do. So in a way, that traumatic memory becomes stored in the brain or lodged in its frozen state. And what happens is it's live. It stresses the person. The person can recall what happened, and the person gets traumatized again and again and again. What EMDR does, it's a psychological therapy to help the person to overcome the traumatic experience by using eye movements and other bilateral stimulation strategies to help the information of what happened to cross over hemispheres and to make sense in the brain. Okay, so we have the event on one side, we have the information to update it on the other side, and it's helping that information to cross over so the person's able to understand and to come to terms with what's happened, therefore being less triggered. Okay, that's a kind of a broad explanation, but I will go through it in more detail. I don't want to focus too much on this, but this is just to give you the lens of which I'm using for this. So the adaptive information processing model holds the primary source of psychopathology is the presence of memories in their adverse life experiences that have been inadequately processed. Okay, normally what happens is you have a memory, it's processed, you learn from it, and you move on from it. Trauma is different. Trauma, again, what happens during trauma is that memory becomes frozen. Okay, and within that memory, the person can maybe see the image, can feel the image, has certain associations with the memory. Maybe they have negative beliefs. I am vulnerable. I'm not good enough. I'm in danger. That's been encoded, and the person gets triggered again and again. So these are appropriately stored memories, which include perceptions, sensations, beliefs, and emotions that occurred at the time of the events, but they're triggered again and again and again. So I always say to my clients, think about a memory like a hand. So if the person had a car accident, but also was involved in a bullying incident, these are two traumatic experiences, and each of these memories may have an image. The person may see something, they may feel something, they may believe something, the body may respond in a certain way. So now you have two hands or two traumatic experiences which you have to look at and help the person to understand and to deal with. So the ALP model really is what EMDR looks at. So what we're saying is a trauma has happened. The traumatic memory becomes blocked at a neurophysiological level. Okay, so think of it like a little block has happened. What EMDR does is it allows the person recalls what happens. Okay, this is after we've built up a trauma timeline, so we know exactly kind of what the person has remembered within their past. Again, this is important so that we know what's going to come up, and the client is able to give us a chronological order about what happened. So EMDR, what we're doing here is we're getting the person to activate the memory, and we're processing the memory through eye movements and tapping. Okay. The reason why we think this is useful is that whenever a person is traumatized, one of the signs, I suppose, the person talks about having difficulty sleeping. And we know that rapid eye movement during sleeping is when the brain tends to process or work out information from what's happened during the day. And we believe that whenever we're doing EMDR therapy, maybe this is one of the useful tools that helps us to process the dysfunctional memory network from traumatic experience. So what EMDR does is it loosens up the frozen memory network. Okay, therefore information can process, processing of the component of the distressing memory, so it allows to process information. Therefore, what you're doing is refiguring and rebalancing the neurological state. Again, if you look at traumatic memory, you have different components of it. So what you're doing is you're holding the memory in mind, you're processing it using eye movements, and it's helping the person maybe that the memory becomes more distant. Maybe I can't really remember it anymore, I can't feel it anymore. Maybe I've got a different balanced view of the memory, therefore I've brought about some sort of resolution, and I'm not going to be triggered again. Okay, have a look at this slide and have a read of it. Again, I put this up to say the brain is very smart. Sometimes it's too smart. Okay, so have a look at this. Okay, so you can see all of those words are jumbled up, but yet we can still read them. Okay, and the reason why I brought this slide up is to remember whenever we're talking about trauma, we're talking about traumatized mind. Okay, and it's important to remember that as well whenever we're dealing with our clients. We're dealing with someone who has been traumatized. Okay, the next slide, okay, what I'm going to talk about for the next few minutes is about trauma and the brain. Okay, I'm going to talk about the physiology and the brain change, again, to reinforce that the research has shown us that when someone has been traumatized, there is a change in the brain functioning. Therefore, if we look back to what I said in the earlier slides, past, present, future, if there's a change in if the person has a traumatic experience, it's going to impact on the symptoms which they're presenting with. But I'm not going into that in more detail. The second thing is the window of tolerance, okay, which we're going to talk about in the next slide as well. Trauma and narrative memories. So traumatic memories and narrative memories, they're different, okay? And let me explain to you in this way. Narrative memory is a memory that you're able to maybe talk about. For example, what happened at the weekend. You may be able to give quite a good story about what he did in order of it. It doesn't necessarily bring on any distress whenever you're talking about it. So that's like a narrative memory. You can see it and you have a fair idea about what happened. Traumatic memories are different. Why? Because they're encoded differently. But what they also do is they tend to interfere with us. So they, rather than us trying to activate the narrative memories, trauma memories come into our heads. Okay, so they're more alive. They cause distress. Sometimes, whenever we're dealing with traumatic memories, it's hard to know where's their beginning, where's their middle, and where's their end. So it all becomes a little bit mixed up and confusing. And it's also frozen. Okay, it's also frozen. Which brings me on to the next bit, which is whenever we're looking at trauma in the brain, fear inhibits learning and growth. And there's some really good, interesting studies done with rats and cats. Okay, and what they're showing is that there's lots of different research, but one thing that stands out is that if you put a cat into a rat's cage or around mice, and then you put the cat in, and then you take away the cat, put in the mouse or the rat. What happens is that the rest of the mice can smell the cat, and they become so overwhelmed or distressed by this that what I've learned is that it actually inhibits their learning by a few hours, maybe even longer. Okay, so the smell of the cat activates the threat, and the rats aren't able to learn or to be able to operate properly with that. So again, fear inhibits learning and growth. So going back to the frozen in time, it's important to learn, this goes on to the next bit I'm talking about, is that the person's developmental age and chronological age may be somewhat different. Okay, so at the moment, for example, I have a client who could be about 5 or 6 years of age. However, developmentally, they're presenting as someone who is 3. Okay, and why is that? Maybe it's because whenever the person was traumatized at 3, the brain hasn't been able to learn properly. So therefore, it's important whenever we're seeing the client, understand the client's journey. What age is this client? Or is the client the same age chronologically, or is there a developmental gap? Okay, so what we have here then is, this is just the adaptive information processing system, what happens. So I'm not going to spend too much time on this, but you can see, number 1, there we have the stimulus, okay? Then we have the thalamus, which regulates the sensory, the gateway to the sensory information. What happens then is the amygdala interprets the emotional significance of the sensory and initiates sympathetic nervous system responses. The next thing is we have the frontal lobe or cortex, which assesses the situation in a graded and adaptive response. So it tries to work out, what is this? For example, if someone came with a gun, it has to work out, is it a real gun, is it a fake gun? But it has to activate it, it's moved way before it's kind of made that response. And lastly, we have the hypothalamus, which prepares information for encoding and memory, encoding it, putting it back in its proper place. So I said there a few minutes ago, and this is something just to keep in mind whenever we are dealing with people who have had PTSD, complex trauma, or trauma, is that it can impact on the brain. Okay, so I have a couple of different things just to make us aware of. The first thing is, research has shown us that the amygdala. So what the amygdala is, like the fire alarm that kicks off the flight and fight response. So after a trauma, the amygdala doesn't recognize the difference between a threat then and a threat now. Okay, so the amygdala is like switched on. So therefore, your client is going to be properly scanning the room, being very hyper aware, being very aware of your proximity to them. So the amygdala has been turned on and it hasn't been turned off. It's hard to understand. They're struggling to understand, am I in threat now, or is it over? The second thing is that the hypothalamus, the learning center. So research suggests that it's smaller and less active, resulting in issues with memory and problem solving. Okay, again, if we're thinking back to a child who maybe have been traumatized, they may be acting as if they may have learning difficulties. So this may be an indication that this person may be traumatized. Something may have happened. Okay, so the learning center is affected. The person can't problem solve. The prefrontal cortex, so the rational decision-making area, so it becomes less active, slowing down the learning of new information that could control the fear. So again, we have another problem there, where the rational and decision-making area is becoming less active and slowed down. And the last difficulty we have there is a nervous system goes into overdrives. What we have there is a shrink. It can shrink the person's window of tolerance, which you're going to want to next. Okay, so what I want really to emphasize in this slide is that a person who is traumatized may have a brain that's traumatized. We have to bear this in mind whenever we're trying to assess the person, whenever we're giving psychoeducation, whenever we're trying to collect information. These are things just to keep in mind. Okay, the window of tolerance. Okay, so, sorry. Okay, the window of tolerance. So the reason I put this slide up is whenever we're dealing with people who are traumatized, it's important to remember that their window of tolerance is slightly narrower than people who haven't been traumatized. So the window of tolerance is a term used to describe the zone of arousal in which the person is able to function most effectively. Okay, this is when the person is able to self-soothe, the person is able to regulate, the person is in their comfort zone. That's when we're inside the window of tolerance. Okay. Again, when the person's traumatized, that becomes narrower. Okay. What happens when the person goes outside the window of tolerance? You can see the person can become at the very top, hyper-aroused. We have anxiety, overwhelmed, outbursts, anger, aggression. Okay. So again, whenever we're thinking about people who are traumatized, it's narrower. Therefore, they can be hyper-aroused a lot more quickly than someone who maybe hasn't had that experience. So they tend to go outside the window of tolerance. Okay. Then we have someone maybe who's hypo-aroused, and this is where you have the dissociation, not being present, autopilot. So again, the person can go down as hypo-aroused. So Why this is important is during therapy, it's important for us to know the client has to be within that window of tolerance to be able to engage in the therapeutic process. So therefore, prior to the person engaging in trauma therapy, maybe they need more skills to be able to ground themselves, to be able to regulate themselves. So again, just something to keep in mind is their window of tolerance. And also maybe the therapist's window of tolerance as well, because it's important for me to know theirs, so that I am not making them hyper or hypo-aroused during my treatment. Okay, so again, just another thing just to keep in mind is the person's window of tolerance. 3Fs: fight, flight, and freeze. Okay, so this is their response to a traumatic experience. And I said back a few slides ago that the brain is very smart, and association is a part of the flight response. It's an involuntary survival network that helps to protect us from danger or threat. Okay, so if flight or fight is not a value and it's not an option, or becomes inactive due to the body becoming overwhelmed, then the freeze response is going to be activated. Okay, so the person has, but the body's worked out, if I fight or run away here, I could be actually in more danger. So what happens? It goes offline. So while dissociation is a helpful strategy at the time of survival, it can arise after the trauma, therefore causing more problems. Okay. We also know that whenever someone reports having dissociation during the traumatic experience, it's more than likely that they're going to have dissociation during treatment again. So you just need to be kind of mindful of that and be aware and look at the clients. If you know that they're dissociating, you can call them back in by even calling their name or coming up with some sort of a tool of being able to ground them in session. Smells, very, very useful. Okay, smells won't have to be processed like the other senses in the brain. Smells will bring you down or ground you very, very fast. So smell, again, is something that can help the person to ground themselves. A really useful tool or measurement tool to help us to measure dissociation is the dissociative experience scale, the DES2. Again, it's a very, very useful tool just to add into your itinerary stuff that you can look at to measure dissociation. Okay, so far what we've covered then is we looked at the different types of trauma, we've talked about the brain, I've given you a brief overview about EMDR therapy, the lens that we're using, and the next thing is about living with trauma, which can be a real challenge. So what do we see? How does a person manage during their life? So what we know is the person's got maybe a lot more stress hormones circulating throughout their body on a regular basis. The person may be very angry, very enraged. The person may present with a lot of anxiety, irritability, flashbacks, okay, difficulty sleeping, flashbacks, panic attacks, memory issues, trouble making decisions, difficulty in thinking and concentrating. And the reason why all of these symptoms are going to be in the DSM anyway, but the reason why I put this up is just to emphasize maybe we need to be a little bit more compassionate whenever we're dealing with people who've had trauma, in that this is their life. So if they're late for appointments, if they're not sleeping well, if they're having panic attacks, if they're having memory issues, if they're not able to take on some of the information that we're telling them, it's because they're living with trauma. It's because they're trying to deal with what's going on. Okay. So in terms, again, go back to the presentation, what I spoke at the very start was about the family. So if you have a mum who's traumatized, that's also going to affect the child and the partner. So this effect of the trauma, again, it circles around and it kind of effect on other people. Okay, we talk about intergenerational trauma. I'm going to be speaking about in a few minutes, where a person or a mum just can't be independent of the trauma. The mum is involved in a family network, so it's going to seep out. It's going to possibly affect other people. Okay, so living with trauma. Another thing maybe to ask yourself is, whenever I'm treating someone who has PTSD or trauma, is, am I treating the anxiety or am I treating the trauma? Am I treating the symptom of the event or am I treating the event? Okay, so from a trauma point of view, it's important to treat the trauma rather than to treat the symptom, because the symptom may not go down until the trauma is dealt with. Okay, the primary source of what's happened. Shame and guilt. Okay, shame and guilt are one of the barriers, one of the major barriers to someone overcoming the trauma. Okay, And I think all of us may have had some experience in our lives where we're a little bit ashamed of or a little bit guilty about. So, and I doubt any of us really want to open up or share it, okay? Because whenever we think about it, whenever we think about an experience ourselves where we felt shamed or guilt, it kind of causes us to clam up a little bit, where we don't really want to talk about it and we feel a little bit vulnerable, okay? So imagine this, imagine our sense of it now, and imagine someone's sense of it whenever they're traumatized, and how exacerbated it can be whenever we think back to that. But whenever we're treating shame and guilt as part of a person who's traumatized, they tend to make some thinking errors, okay? And here's just a list of some of the thinking errors. Again, what this can be used for is to carry forward and to be aware whenever you're doing history. These are some things that the person may be talking about. So the first thing is a hindsight bias. This is the believing that you knew the event would happen. Okay, so some might say to you, well, I should have known, I should have known that was going to happen. Okay, what they're doing there is they're hindsight. They're looking back at it, but they're looking back at it from an inaccurate point of view, where they're now in a room, whereas back then they could have been in a different environment. Okay, so that's a hindsight bias. So what you're doing here is you may be updating the person's knowledge about what happened. Why? Because you want to maybe reduce the person's shame, guilt, and help them to see the experience from more of a objective point of view. The second thing is exaggerating my role in the event, failing to consider the other components of the event. It's my fault, but it's about trying to understand there's a lot more variables than just that. Okay, the idea that I could have prevented it does not mean that I caused it. Okay, and this can go back to parents. The next slide, the next bit there is assuming that because I was accountable, I had the power to change or to challenge. To change, to alter the change. So it was my job. I was supposed to look after him. Okay. So assuming that because I was accountable, I had the power to change what was going to happen. Again, it's not accurate. What else should I have done? What else could I have done? Thinking back and again, shame and guilt. Okay. So what do we do then? How do we help the person to overcome their shame and guilt? And I think what we need to do is, the first thing is understand the person, help them to understand themselves. And the goal which you want to get them is to be compassionate with what's happened, to be compassionate about the event. Okay. Sometimes people can't, compassion is just too far, they just can't get there. So maybe understanding is a good enough goal at this time to understand what happened, and then to be more compassionate about it maybe as time goes on. Okay, so this is the last and second. This is the last pause in the session. And again, what I want you to do again is to go back to what the exercise did earlier on. So this is kind of recapping, and it's writing down. Just take a few moments to write down what have I learned so far. Again, I've covered quite a lot of material, but it's just about what's relevant to you, what's relevant to your client. So I'm going to give you 5 minutes for this exercise. Okay. And the idea is to think back to your client at the start of the session. Has my understanding of the client improved? Have I learned any more? Is there any questions that I haven't asked? Is there things that I haven't seen? What do I know now? What's changed? Okay. What do I need to know more about? Is there questions that I haven't asked? How will this improve my practice? So now that I've learned this, so what am I going to do? How is it going to change it? Okay. And update the past, the present, and the future. Okay, so those are the 3 prongs, the EMDR prongs. What do we know about the person's past, the present symptomology, and their future? So maybe if you take 5 minutes for this exercise, and again, if there's any questions, you can just make a note of those, and then we'll hopefully be able to answer them in a few minutes. Okay, so I'll just go off there and just give us some time to have a look and to think about about the first slide. Okay, welcome back, everybody. Okay, so I'm just going to continue on with the presentation. Okay, the next thing is being traumatized at the hands of others. So at the earlier start of the presentation, I spoke about, it's about understanding, was it at the hands of someone else? Was it the hands of a relative? Was it a natural disaster? Was it an accident? What happened? Was it a car accident? So this is being traumatized at the hands of others. Okay, so what we know is this has happened. There's a higher rate of complex PTSD. So the person is more likely to develop complex PTSD. The person is also probably going to present with shame, self-loathing. Okay, it's going to be higher. Traumatized attachments. Okay, attachments is something that I haven't really talked too much about, but again, it's a big area in trauma. So attachments is really if the person has secure attachments to a family, to have good friends network, it may be a really good resource from preventing the person from being traumatized. But I suppose when someone has been traumatized at the hands of maybe a parent or a brother or someone who they trust, that can really impact on the person where the trust is lost, and it's hard to then develop trust in relationships with their partners. So traumatized attachments, again, it's just something to be aware of. They may be more increased if the person has been traumatized at the hands of other people. Fragmented minds, what I mean by this is that maybe the person's memory of the incident may be more fragmented. Okay, so some people, whenever they think back to what happened, they can see the memory as being clear. Maybe we can see it as being more vague. Maybe it's fragmented, but there's little bits and pieces, but they can't really see it, but they can feel it. It's the fragmented minds. Interpersonal issues, okay? What I've noticed in my practice and from doing this for a while is that often people who have complex PTSD also report interpersonal issues, okay? Again, it's difficult to establish, maintain relationships. They often self-sabotage it. Why? Because it's happened to me in the past and it's difficult for me to trust people again. So interpersonal issues, again, it's very common. It's a very common thing to see. A lack of safeness, safety. If you think of someone who's been traumatized when they were a child, if it was mum or dad was involved, their safeness is they don't have a lack of safeness. Maybe it's difficult to get that wasn't given to them. So therefore, safeness isn't a given. It's difficult to get that. Some people even struggle to think of a place where it's safe, and we have to help them to build a place in their mind where it can be safe. So again, lack of safeness. Memory disorganization. Maybe their memories of what's happened again. Maybe there's lots of different memories. Maybe it's hard to understand what happened. But often the person will remember in the body again, where they feel it in the body and what happened. So the memory again disorganized. And their sense of self is shaped by the trauma, both intra and interpersonally. So what's happened has affected the person's relationships and other relationships from that. So again, if you think about it like, I suppose, a drop of water, there's a ripple effect. So you have the person who is traumatized, and then the traumatization, I suppose, of the person's symptoms kind of stretch out, and affect other people. Okay, this slide isn't very clear, but I think the gist of what I'm trying to say here, going back to the topic, which is the family, is we have a mum who's struggling, and we have two children. Okay, you can see that the mum has her hands on her forehead. But the man has got the idea, I'm powerless, I'm a bad parent, my child is being bad and manipulative. So the man there seems to be struggling. Maybe she has isolated herself, maybe she has dissociated. So it's possible what we're dealing with here, which you can see over here, is we're dealing with a parent who's carrying the trauma, and she's going back to her own self, her own maybe youth, and she can see herself in this. Okay. So it's possible then that the mum's lack of internal safety is being triggered whenever her two children are playing, or whenever they're acting out. Okay, now her sense of safety may have also impacted on the children's sense of safety or lack of internal safety. Okay, why? Because maybe mum's not there. Maybe in some cases, children tend to take on the role of the parents. They become the parent, and maybe they're trying to help the mum to be okay. Check, are you okay, mum, and stuff like this. So again, the roles have somewhat been reversed. Then there's growth inhibited emotionally and somatically. Okay, so again, going back to what I said before, is the chronological age may not equal the developmental age. So whenever we're taking a history, it's important to understand when did the trauma happen, how is the person presenting, and is there signs of when a trauma may have happened. So children maybe who are traumatized, maybe acting out behavioral issues. They were in school doing very, very well, and then suddenly things started to be very, very difficult. They couldn't concentrate. They found they weren't safe in school. So what you're seeing then is symptoms of something that's happened. Shame, guilt, anger, fear, fight or flight response here is this little boy over here. Okay, so again, what we're seeing here is intergenerational trauma. And Anna Gomez has written lots of really interesting stuff about intergenerational trauma and EMDR. She's a really good resource for the person to read about if you want to learn more about this. Okay, so we're coming to the end of the presentation, but just to recap, okay, so I've gone through quite a lot of information, okay, so what do I want to, the main important thing is to try to understand the client's journey. So from an assessment point of view, it's important to understand the developmental history. What was the person, how are they getting on with achieving the milestones, the family history, a trauma timeline, okay, what happened, when did it happen, can they remember, so the two of us can build up a trauma timeline. We both know what the events that happened, the age it happened, who was involved in it, how the person responds to it, how they feel about it. All these things help us to build it up. The current symptoms, there's a book written, The Body Holds a Score. So the person may have spoken to lots of different people about it. It's helping to understand, but they still feel it. Why? Because the body feels it. It hasn't been able to let go of what's happened. What's the person on for the medication? What medication they're on, or what's the person's goals? What do they want? What are they looking for? Okay. Some useful questionnaires just to help with assessment, which I find quite useful, is the PCL5. It's a really useful questionnaire, and it comes off the DSM-5. So a lot of the symptoms are the person can tick a little box for how much that they have nightmares, that they're flashbacks, that they're difficulty sleeping, about a sense of poor concentration. So all of the kind of symptoms that you look out for PTSD is in a nice little scale. It's very useful because it also opens up a conversation where if the person tells you that they have a lot of flashbacks or nightmares, it'd be interesting to know what they're about. Has it happened, or is it kind of a version of what's happened? How much is it affecting their sleep pattern, the concentration, what's going on there? So it's a very useful tool to open up a conversation about the person's difficulties, and it's also a really good tool to make sure that we're doing the right thing in terms of helping the person to go back to normal life. Is their sleep improving? Is there flashbacks? Are they improving? What's the areas that need to be looked at? Okay, so I think it's a really useful tool and something that I use a lot. ACE, I'm going to go on to the few seconds. The Adverse Child Experience Scale. Again, really good research done on this, and something I'm going to speak to about in a few minutes, but I'll put that in. Again, it's a very useful questionnaire to have and to understand the person. And another useful one is the DES2, the Dissociation Scale. It gives us an idea about how much the person dissociates presently, so that whenever we're treating the person, we'll know what to look out for, and we'll know what improvements that we're making towards the end of the journey. So ACE, the Adverse Childhood Experience, ACE. Okay, so you may or may not come across this, but there's some really good stuff written on it. So the Adverse Childhood Experience with the ACE are potentially traumatic events that occurred in childhood from 0 to 17. For example, experiencing violence, abuse, neglect, witnessing violence in the home and community, having a family member attempt or die by suicide. Okay. Also included are aspects of the child's environment that can undermine their sense of safety, stability, bonding, such as growing up in a household where substance was a problem, mental health problems, instability due to parental separation, or household members being in jail or prison. ACE are linked to chronic health problems, mental health issues, and substance difficulties. So ACE, the person who's got a higher ACE score, it can have a negative impact on their education, job opportunities, and earning potentials. And so there's some really cool videos out there as well to help people to understand what about ACE and what can be done to reduce ACE scores. So the next slide is a very useful, next slide is a very useful pyramid. Okay, so what you can see here is it goes from bottom to top. Okay, that's the very top. So has a person had adverse childhood experience? Is there a disrupted neurodevelopment? Has a person got emotional cognitive impairment? Is there risk of health issues, disease, disability, and social problems and early death? So the ACE, what the ACE study does, which went from 1998 to 2015, is it's got a list of questions and it helps to predict the person's outcome based on it. So the ACE study is really it's looking at the link between childhood trauma and chronic diseases of people who've gone on to adulthood. These include heart disease, lung cancer, diabetes, and many other autoimmune diseases. Also depression, violence, etc. Okay, so I suppose it's kind of like a predictor of what the person may develop given their history. So again, something just to look up if you're interested in it, just to have it in mind as an assessment tool. I think psychoeducation is a really important part of helping the person overcome trauma. Psychoeducation is a lot of what we've spoken about so far today, helping the person to make sense of the trauma and for you to make sense of to join the person on that. So clients need an explanation in order to account for their symptoms and experiences. They really need and they're trying to understand what is going on, how come I'm here today, and what's happened to me. So they need a strategy on what they can do to alleviate the symptoms. Compassion is the antidote to shame. Sometimes compassion is too far. Maybe understanding is a better benchmark, a better place to get to. So teaching the child about trauma and some hindsight biases which we may be experiencing. Fear inhibits the person's ability to learn. Okay, go back to study with mice and cats. If we're in a place where there is instability, where mum or dad or there's some sort of conflict in the house or instability, it's hard to learn. Okay, so we need to keep this in mind whenever we're looking at the client and their ability. And like I said, sometimes compassion is too hard to achieve. Understanding is as far as somebody can go. So psychoeducation helping the person to understand, such as how the brain has changed, how memory is a little bit different. All these things can help the child, the adult, or the adolescent to understand. Okay, so this is what I'm going through. What else can be done? Okay, so grounding. Back to what I said earlier on about the window of tolerance. It's about the person being able to be present today. Okay, so what can be useful is helping the person to ground themselves using the senses. Okay, using taste. Okay, maybe having some sort of a sweet or something sour to be able to ground themselves. Touching, smelling. Okay, smelling is one of the most important and useful grounding tools. Why? Because it doesn't have to be processed by your, like with the other senses, the eyes and your ears. So smell is something which will rapidly help the person to ground themselves. And you can see it yourself if you walk into a room and you smell something, you're automatically taken back to a place where it's like deja vu. I've smelt it before. So smelling is a really useful thing to help the person to ground themselves. Also hearing like having music, and breathing, meditation. Okay. What else can help the person? Knowledge of the person's story and helping their narrative to guide your intervention. Understanding, taking time to listen and get into their world. The evidence for the therapies which can be used for treat PTSD, CBT has got a very good evidence base, and EMDR has also got a very good evidence base. So two of those is just suggestive. There's also the therapies around, but these have got good evidence for the treatment of PTSD. Okay, that is the end of my presentation, and I'm happy to take any questions if anyone wants to ask me anything or any feedback.
Hello, hi James. Thanks for that. I just wanted to ask you about, you were saying about treating the trauma rather, I didn't catch that bit.
Yeah, of course, of course. So some people may present and they may have been traumatized, and then what they present with is symptoms of the trauma. So somebody could have had a car accident many years ago, and now what they're presenting with is anxiety and depression. So it makes sense then to treat the trauma first, if it's possible, rather than trying to reduce the anxiety and the depression, because that's fed from the trauma. That's fed from an EMDR point of view. That's fed from the dysfunctional memory network. Does that make sense?
I just wonder if you could, give a little bit more about that. How would you kind of treat a trauma that's happened that far back?
Oh, so how I would treat it would be using EMDR therapy, which I've kind of touched on, but I haven't really gone into it. So what I would do is I get the person's trauma timeline, so I'd know which traumas had happened. So the person could have had 1 or 2 or 3 traumas. Okay, I'd also be mindful of their current symptomology and their future outlook. So using the 3 kind of the past, the present, and the future, the 3 prongs. And from an EMDR point of view, what you're trying to do is you're trying to get the person, well, first of all, the person needs to be able to engage in the therapy and regulate it. But what you do is you get the person to briefly think back to the incident. Okay, so now the memory or the information has gone from their long-term memory into the working memory. It's there in their mind and they can feel it in their body. Each memory comes with a different component. So we have a target, we have an image of what you can see, we have a cognition. So the person may have the belief that I am not good enough or I'm vulnerable. So you want to get them to more of a stable place. You get them to kind of, I suppose, mark where I am at the moment and where I'd like to be. Okay. Each trauma generally has an emotional component where they can feel it in the body. Whenever I think back to this incident, I feel angry, I feel upset, I don't feel anything. They can have emotional component. And the last part of memory will be the sensations, where the person feels it in their body. So by getting the person to think back to the event, even just a quick little flick with their mind, and by getting the person to engage in EMDR therapy, which is where they'd look at your fingers go over and back for about 30 seconds, or there's tapping, there's lots of different variations. So what you're doing here is you're getting the person to think about the memory, but you're also using bilateral stimulation, basically getting the person to look over and back, okay, or to be involved in tapping. And the reason why we think this is useful is that we're activating. It's one of the theories behind it, that we're activating the rapid eye movement cycle, but the person is conscious during it. Okay. And what you'll notice is that during EMDR therapy, that memory of what's happened becomes more faded, more vague. The person's got a different understanding of it. So that's kind of what EMDR therapy looks like. So therefore, what you're doing is you're treating the problem rather than treating the symptom.
All right, that's great. Thanks very much.
No problem. No problem.
Hi, James. Thanks for that talk. That was brilliant. I was just wondering, for anyone who's interested in kind of, trying to qualify in EMDR, kind of study a bit further, just would you have any recommendations in terms of where to go or how to do a bit more training?
Of course. So if you go on to, there's EMDR All Ireland. So basically, there's EMDR UK, there's EMDR All Ireland, there's the EMDR in most countries at the moment. So if you go on to EMDR All Ireland website, the president there is Gus Murray. And you'll be able to have a look at the guidelines, and then Gus does a lot of training programs, so you'll be able to fill an application form and try to apply for one of those trainings.
Brilliant, thank you.
No problem.
Okay.
Any other questions?
There's just questions in, James, there. I'm just going back through them. The PowerPoint, any of you that have registered, we can send that directly to your emails. Thank you, says Michelle. Very insightful topic. I agree. And all that stuff with the children. I have smaller kids. It's fascinating, to be honest with you. Now, from Francesca. It sounds like an Italian second name, so I'm not even going to try it, Francesca, and I hope I'm pronouncing your first name right. She says, is EMDR a standalone type of treatment, or does it require the support of other therapies such as CBT?
Okay, good question. I think what EMDR, from what I gather, people who are going to do EMDR training come with a certain level of expertise already. But EMDR has got its modalities in several different therapies. So I suppose you'd be using a bit of cognitive stuff could be used whenever people get blocked. What I mean by that is whenever sometimes people are trying to go back to memories and trying to process, sometimes there's the block or the loop. And in those circumstances, a cognitive interweave can be useful. So what we're trying to say here is that people generally come to training with a certain degree of expertise, but also EMDR has got it comes from other modalities where your also mindfulness comes into it, where you're being present. So it kind of takes a lot of different elements of other therapies involved. I think CBT is very useful because I use a CBT formulation, which kind of helps me to kind of help people whenever they're in the present and the struggle to get back to doing certain things. So I would switch on my CBT hat and look at maybe anxiety from a more exposure point of view. So I use kind of both. But I think from what I gather, a lot of people come with a lot of different specialities already to do an EMDR.
Lovely. Any other questions there now? Please feel free to hop in for anybody that has queries. Oh, you're welcome. Francesca just said thank you, James.
No problem. No problem.
Is there anything else? I don't want to delay, you know, that's what I'm saying. We don't want to drag it out unnecessarily and sit here wasting your time. So again, if there's questions, pop them in there now, and you have James at your fingertips. And if not, we'll kind of conclude. I don't see, I'm just giving it a minute, James.
Okay, that's no problem. That's no problem.
Is everybody happy?
Yeah.
Yeah, sorry, missed earlier, said Miriam, and great to have this. Great. And look at James, I'm thinking, you know, we might run this obviously again as part of the January to June kind of program. But is there the next level up, or do you know what I mean? If people were doing it for a little while, does it get more advanced? Do you know what I'm saying? Like, this sounded very kind of an introductory level to get people started. So yeah, it sounds very specialized from what you're describing.
Yeah, it would be. I suppose whenever people do EMDR training, there's generally an adult component first, and then there's a child adolescent, which is the second, another level of training. So what I've tried to do is just to even ping different ideas so that people know that there is stuff out there. So it is quite specialized. I could do different other areas. I just need to kind of think about what I was doing. This is just like a kind of like a flavor or an introduction, or just to let people know that this is what's out there. But more importantly, this is the way that what's shaped my kind of nursing practice and how I see people differently.
Yeah, no, very interesting. So Fiona says, thank you so much for a wonderful presentation. Mary Wall, many thanks, so very interesting and important. And Laura O'D says, thank you very much, James. Very interesting topic and easy to follow. Yeah, and I thought, like, I'm not psychiatry background. My background is intensive care, whereas it was a really I suppose it gets me thinking too about my own life and just you know what I mean? Yeah. You don't think about these things too much. And that bit about the food, James, the smells. You are so right. You know the way there's even brown bread and things, I immediately go back to my nana's house. You know, there's certain things that
exactly. Yes.
Trigger. It's fascinating. Yeah.
It back. It does. Yes.
That's what I'm saying to you. And to kind of see that being used in, like you say, this way is really fascinating. I presume this is an area that will kind of become much bigger, I would say.
Absolutely. EMDR therapy, thankfully, is growing. So the community is growing, and yeah, it is. And I think trauma, even with younger children, we're learning more and more about it. So it's fantastic, and you know, it's great for children even at that age. Like at the moment, I'm specialising in that area, so I'm dealing now with maybe 5-year-olds, 6-year-olds. It's great that these kids can get treatment now rather than the symptoms. You know, being there, but it also, I think, explains how can kids who have had a trauma, maybe that's why they're not able to kind of learn things. Maybe that's why there's a bit of a delay. So it kind of helps people to understand what's going on And again, I suppose whenever I'm dealing with someone, I always have the back of my mind, has something happened? Are we dealing with trauma here, or am I dealing with something else? So it's, again, it's sort of a little window that I'm always looking through.
I know what you mean. So listen, I don't see any more questions. I'm going to thank everybody. Oh, sorry, Anne-Marie Delaney says, thank you, James. Very interesting, a great presentation. And I think we all agree with that. So listen, thank you, everybody. From what I'm counting, we had about 23 of you on. So look, I know the services are busy and everyone is, you know, COVID is bad again out there. So we really are grateful for your time. Hope you found it beneficial and useful for your practice, more importantly. And James, thank you for your time, because really, it's really having experts like you available to the collaboration is what makes it so strong. And again, you can put all of what you're talking about theoretically into practice, which is really helpful for us to certainly listening as to how it works in real life. So have a great day, everybody. Have a good week. I should be advertising the next program. So Anya, do you have a slide? We didn't actually think this far ahead. When is our next date, Anya? Anya. She doesn't. She might, I don't know. She's definitely here. I will send it out by email when we send out your certs. Sorry, I didn't even think of that coming on this morning. Oh, there you are. Do you know the next date by off in the top of your head?
So our next CPD is next Wednesday. It's an overview of that in life expectancy.
Hello. We can't hear you.
Can you hear me?
Yes, there you go. Yeah. Hello.
Can you hear me?
Yeah, you're breaking up a lot though. Go again now. We might be third time lucky.
Sorry about this, everyone. Our next CPD is next Wednesday.
Yeah.
And it is Sheila Kokoman. Sheila Wickham and Angela Kokoman. And it's an overview of the gap in life expectancy. So when I'm sending out the certs, all the information is available on the PNA website. But when I'm sending out the certs and the slides, I will send out the full program as well.
Great. So she's going to send you out the full program, but it's all on the PNA. It's advertised through them. Obviously, the collaboration is run for their members. It's definitely next Wednesday. It's around. It's same time. We've gone with 11 to 12:30 for all of these, and it's with Dr. Angela Kokoman and Professor Sheila Wickham, and it's looking at. I can't remember. I didn't really hear what Anya told us there, but it's looking definitely. Their three talks are focusing around physical issues in obviously patients with mental health. So they have a series of 3 of them, and some of them focus on chronic disease management, diabetes, heart failure, or cardiovascular disease, obesity, and they're looking at the gaps and inequalities and how that can be managed. And I know they have one then about different assessment tools and things. So look, we will hopefully see some of you back next Wednesday. Have a great afternoon, and we will talk to you next Wednesday. That all right?
Thank you. Bye-bye.
Bye. Are you happy, James?
Yeah, I'm happy. Yeah.
Brilliant. I think, look, it was nice to be able to see people today. I think that was just brilliant.
Yeah, totally. No, it was great. I actually didn't see anybody until now because I had whatever way I had it set.
Oh, I know what you mean. So look, I don't know, is there a way that you can kind of see them as opposed to just the slides?
No, totally. But to be honest, I actually found it easier because at least, I wasn't distracted by people in the background.
Yeah. No, it's fascinating area, James. I knew nothing about it now, and that's what I'm saying. I just found it, even when you're thinking about children and how what is a trauma like?
Yeah, of course.
Fascinating. So people are logging off there now. So look, we definitely will, I think, do this again, James, over the January. We kind of will aim to run it now again, January. We kind of start the middle of January till maybe May kind of time, because once we get into the summertime, people start to go on holidays. But like you say, it's a topic, I think that you'll see that becoming much bigger from what you're describing.
Yeah, I think so. I think even myself and my colleagues are seeing a bigger increase in children coming into us, 6 years of age, 9, below it. And again, it takes a lot more specialization. I suppose I'm really lucky in that I have a guy over in the UK who's very advanced in what he's doing.
Great.
So he's kind of my guide at the moment for taking
Brilliant.
these kids.
Yeah.
So I suppose from having my daughter myself, it's kind of easier for me to learn on the go. So now I know what child free looks like and what she talks about. So it's really to have her to learn what I'm doing.
No, yeah, no, it's fascinating. Like you say, and you can kind of see it, you know. That's really amazing. You're excellent, James. Like I found it really, it's really a growing area. So look, we will let you go, and I will talk to you. We will sort a new date for January, but I think this one isn't as relevant, James, to the clinical nurses in a lot of the general. Does that make sense?
Yeah, totally. Yeah, totally.
So we might do something on resilience or something kind of, you know, supporting them in their work, because COVID now, from what I see in the paper and just talking to my own friends, it's people, the services are getting really busy and stressed to get, you know, just turnover. So maybe there's something that would, you know, like you say, just helping them to help. I don't know, it's not to say strong, but just, you know, for their own, just kind of getting through work. Does that make sense? So we might do one of them before Christmas maybe, but we'll come back to you on that. So look, I am gone, and I thank you so much, James. Like, that was excellent. James. You see them still coming in there now. There's people saying thank you. And we'll be better. I forgot all about the second. It's a good time to tell them about next week, and I forgot all about that. Sure, I could have had the slide open on you. I'm sorry about that.
I'm so sorry. My mic, I don't know what's happened to it. It's gone wonky. But yeah, I'll send all that information out to everyone.
Yeah, that'd be great. Now, Miriam says there, it's so sad that there's no services available, even though nurses are qualified to offer this. Oh, why is that, James? Is there a specific? Is it to do with insurance, or the service has to approve it, or how does that work?
I'm not sure. I mean, I used to be in the board, but I stepped in there a while ago, so I'm not sure what's going on at the moment.
She says in mental health, no service available, even though nurse qualified to offer this in mental health. Yeah, that's not great.
Yeah.
Maybe as new kind of treatments, does it take a while to kind of get them established? Maybe.
Yeah, I don't know. I suppose the last time I was in, nurses were allowed to apply, but then I heard in the grapevine that there was some difficulty with there was something going on in the UK where they were looking at it. So I don't know how the guidelines changed in the last few weeks or something, but I don't know.
Okay. Well, one to keep an eye on. And Arcana says, thanks for this topic. Really a good presentation. Very informative. Thanks. So that's great. Lovely comments there, James.
I think I suppose accessing the website will give you the best guidance as to what's the current update on
no. Yeah. No, that sounded great. So look at James, Anya will be in contact, and thank you so much.
No problem.
All right.
Take care. Bye-bye.
Mind yourself. Thanks, Anya.
Bye.
Anya. Bye-bye.